Okay, there's a reason for this. I'm interested in data. I think we're all interested in data, and we've been talking in great length already about the need to collect relevant, structured data and to be able to access tools to analyse it. And I think the registry is offering a unique opportunity to transform the ability of UK IBD community to undertake research. And it's a very sort of democratic process because any hospital with a web connection can now get involved in research and have hopefully some tools and facilitation to allow research to flourish. The registry is a tool for collecting data for all sorts of purposes, and my interests are around data and trying to bring some additional value to what the registry can offer in terms of data reporting. Now, we live in a big data age, don't we? So if you spend a few quid on a device for your bike, you can get home and you can know how far you've travelled, what your average power is, how many hills you've climbed. That data can be linked to all sorts of information that you don't have but is already collected, so you know where you've been in the different parts of the country. But of course, in the NHS, it's an absolute struggle to collect any sort of structured data in a standardised way and then leverage that into research. So if you ask your trust to provide you some information, some data about what are we doing in the IBD service, let's just get to the basic beans right first of all. How many patients with IBD am I seeing? We don't know. We know how many new patients I'm seeing, we know how many follow-ups, but we don't know who's got IBD and who hasn't. So really, the data quality of what is collected routinely in the NHS and can be analysed in an IBD-specific way is very poor, and it shouldn't be that way. And part of it relates to the infrastructure and the IT investment in the UK, but part of it relates to how we practice and what we do in terms of our day-to-day contacts with patients. So we were promised an information revolution in the NHS, and there are wonderful electronic health records out there, but it hasn't happened, has it? And I think most of us who sit in our clinics, we don't have systems that facilitate the collection of the sort of rich data we'd like to have. It's well recognised now that a different paradigm of research is emerging, and real-world data and being able to describe what happens to patients treated in the realities of specific healthcare systems is important, and pharma are very interested in this. And embedded in the IBD standards, that the ability to perform research, whether that be a small local project for the registrars to get involved with, right through to a multi-centre trial. Research is positive, supports innovation, supports quality services, and yet there are all sorts of barriers and hills along the way to thwart us. And I do think that the registry system and the tools and the infrastructure around it is starting to enable research activity to take off. So we were very pleased and honoured, I think, really, to be given funding from Crohn's and Colitis UK to support this, because the registry is quite clearly a high-risk project, and the Health Services Development Award from CCUK was applied for and funded to try to accelerate the informatics and the data side of the registry. And I think put back one important thing, because I think a key question for people is, what do we get back from the registry? What are we getting out of it? If we put data in, what is it giving us? And that's been slow to develop, and I think that was inevitable. But what I saw and what the group that applied for this grant wanted to try to achieve is to actually harness data that exists already in order to provide some information back. So if you're a registry participant, it's not simply about the data you put in, but you'll get some additional value added, which will support your local services, local audit, but also be a tool for research and for researchers and for people planning research. So that there's an incremental benefit and something that you get back that's beyond what you're putting in. So we've had a couple of abstracts at the meeting already. We're about 6 months into the project. And most of the focus has been about harnessing the routine data. I alluded to the fact that activity data is collected by trusts, but it's not well analysed, and it's certainly not brought together for your IBD population because you don't know who they are. So the main thrust of the project has been to develop and test new ways to look at routine data, and then explore linking that data, once we've analysed it in more intelligent ways, linking it to items of data within the registry dataset, and at all stages consult. We want to know what people want, what people need, what sorts of metrics and information they want derived from routine data, and then incrementally from aspects of the data collected to the registry. So we've started with basic data sets, and these are crude, and we are provided increasingly with our informatics departments in hospitals distillates or analyses of these data, but they're very often not perceived as being valid. They're certainly quite difficult to get data that's relevant to our IBD population. And so what we've done is undertaken quite a prolonged series of analyses and interrogations of national HES data. We've got 10 years of data for all your hospitals in England, and we've tried to generate algorithms and filters to produce outputs that we hope are useful to you, not only in terms of improving research capability and supporting, for example, long-term follow-up of patients without the need to collect data, but also at the coalface in terms of reducing information. So getting the basic beans and activity count right and presenting them back to you in a usable format. So whilst Fraser is busily away at Southampton actually collecting registry data, and he can now map his sort of catchment area, which I think is quite nice. We've been beavering away with the HES data and trying to categorize this information in ways that allow us to produce activity, process, and outcome metrics, which we hope are useful and relevant. And so we've produced some reports and shared them with a number of hospitals. And the first thing we're able to say is, well, how many IBD patients are on the radar at your hospital? Now, some of you may have wonderful databases, but most of us don't. And so we've trawled through 10 years of data to find any patient ever coded with inflammatory bowel disease. And now I can tell Fraser that 5,000 patients plus have been through that system. And now we've got the identifiers of those patients. We can just produce all sorts of information about that cohort. It won't be the whole IBD cohort, but when the audit used to capture 20 cases, we've got 5,000 cases now in his local hospital, and we can provide activity and process reports from the HES data for a given data year. We can look at absolutely every contact with the NHS, outpatients, A&E attendances, all cause admissions to the hospital. And we've spent months working on algorithms to see if we can analyse that data meaningfully in the context of IBD. So we can look at emergency admissions. Now this sort of thing, primary diagnosis of IBD, that's what your informatics department will give you. But it's woefully inaccurate because in actual fact, much of the data, much of the admissions for IBD are actually coded in a variety of ways. So if you're admitted with a perianal abscess with IBD, that may be the only code. So the coders at the hospital won't find that patient's got Crohn's disease, and that'll be missed off any report they generate. But we've now got 5,000 patients at Fraser's Hospital that we can find every single admission. And if we think that primary diagnosis is relevant, we can aggregate that. And so we've got a whole series of ways of presenting this data, admissions for iron deficiency anemia, the data belonging to the patients with IBD that we've already identified. Now this is from HES, but imagine if you've got your whole IBD patient population and we can link that through to the routine data. Then we can describe all the activity that your hospital is capturing for that population. And we can look at surgery procedures, etc. We can give you time course. So what's happening with my outpatient activity? You can get raw numbers from your trust, but this is the IBD patients, and these are the number of admissions, these are the numbers of elective procedures. So temporal trends. So no more of this rather crude data from trust, but hopefully moving to an era where we actually are harnessing the power of the routine data that all hospitals collect, crude that it may well be, but hopefully harnessed and used in a more efficient way and potentially supporting research. So that's the routine data, but what if we start linking now this routine data to individual items of data from the registry? Let's take a simple example. We're focusing on biologics. So let's suppose we recorded just one item of data, the start date of a biological treatment. And if we then link that through to the routine data, so you sit in your clinic, simply registered a patient and put the start date for the biologics. What we can do now is track 30 days, 90 days, a year before or a year after within the routine data. And this is hot off the press, but this is basically a group of patients that were entered into the registry. And at the coalface, all that was entered was, here's my patient, this is the start date. We've put that through and linked it with the routine data, and now we can tell you all-cause emergency admissions in the year before and after the start date for your group of patients, total emergency bed days, emergency admissions to the primary diagnosis, admissions for anal rectal conditions. So this is a year before, a year after. Your trust collected and coded this data, but you don't have access to it. By participating in the registry, entering some simple items of data, we can now start constructing reports. This may not be of interest, but I hope for the IBD audit, the transitional programme, knowing resource use for a year before and year after within the UK for 3,000 patients with IBD is going to be quite useful and potentially publishable. But more importantly, at the coalface, important information to show your funders that your biologics use is potentially saving inpatient activity. So that's one example. in the interest of time, I'm not going to speak too much about the portal, but moving on from routine data, from linking a small amount of data from the registry, the potential for collecting clinically rich data in the registry is enormous, and I won't spend time going through, but it's a very detailed, very comprehensive data set. It's covering issues such as consent, which are thorny, but a sort of a roadmap through here. If you wanted to set up a study or a trial, you register for the web tool. Within days, you've got a bespoke system with a complex, structured electronic data set, facilitation of how you go about consent, recording serial contacts, an ability to record investigations, medication stop dates, disease scores, patient-reported outcome measures. So as a tool for whatever research interest you have, I think it's potentially a game changer for many units. And the key thing is not the registry's data. This is your data. You can collect the data in one or multiple centres, export it and analyse yourself. The governance around the data access and who has the rights to use the data, it's dependent on consent and it's project specific. So if you want to design a study or fund a study using the registry infrastructure, that's your data and you'll have access to it. And I think it's quite clear that that sort of clinically rich data can support a whole variety of study designs and types. So I think what the registry is potentially offering is an enormous toolkit and a way of facilitating research. A great deal of thought has been put into standardising and producing a structured data set. So for the research naive or those who want to get on the ladder for IBD research, there's a great deal of thought already gone into the data items. There are tools to collect the data. As I mentioned before, you simply have to have an internet connection to use the web tool. Don't need to worry about the data warehousing. The consent model is built in, and consent is becoming enormously thorny and a huge barrier to research. And at least some significant thought has been gone into the registry and the way of recording consent. You can export the data, and alongside whatever data analytics you want to throw at your study, the registry is developing ways not only to analyse the registry data, but also to harness the routine data and provide some added value back to support research. Quite how that will work in terms of applications and funding is being formalised, but the key message is that this is a tool that we want the whole IBD research community to harness and use. And Fraser will talk shortly about some proof of concept studies which will further illustrate. So I think there are all sorts of mountains to climb in terms of harnessing the registry for research, but I think it's a once-in-a-lifetime opportunity, a bit like the vote today, and certainly I'm convinced that the trajectory it has now and the potential is enormous. Thank you.